Good afternoon, everyone, and thank you for joining us today. I'm Dr. Wilcox, the Community Coordinator at the New Jersey Healthcare Quality Institute. The Quality Institute is a nonprofit, multi-stakeholder advocate for the safety, quality, and affordability of healthcare for everyone. The Quality Institute oversees a statewide community health initiative called Conversation of Your Life, also known as COYL, which is a program of our Mayor's Wellness Campaign. So COYL aims to engage communities and residents in crucial advanced care planning conversations, and we discuss topics like how to communicate your wishes to your loved ones and healthcare providers, hospice and palliative care, and various advanced directive documents. Our programming is being adapted to various cultures and languages. Now, we don't know when a medical emergency or public health crisis is going to occur, and the COVID-19 pandemic has prompted many of us to consider the advanced care directives that we may have been putting off. And we want to make sure that you have as much information and resources that you need to help you make the decisions about the type of care that you want. So we're going to continue to provide resources and have these crucial conversations remotely through digital resources, podcasts, and webinars like this one here today. So before I begin, I want to go over a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit background noise, and you may ask questions at the end of the presentation by typing into the chat box. So the topic for today's presentation is Conversation of Your Life and Planning for a Medical Emergency. Please be advised that it is not the intent of this program or its speakers to provide clinical or legal advice. So today, we are honored to have Rachel Rubenfeld, MSN, APN, FNPC, Palliative Care APN at Central State Medical Center joining us for the presentation. And afterwards, after the presentation's over, we'll have some time for Q&A sessions from the audience. So I wanted to begin with defining what advanced care planning is. So advanced care planning, it's the steps that you can take to plan ahead for your future. It involves making decisions about the kind of care you would or would not want to receive if you became ill or had an unexpected medical crisis and could no longer make your own decisions, and planning for this care ahead of time. It's really about understanding all the options that are available to you, considering what you want, communicating your wishes to your healthcare providers and those who matter the most to you, and putting those wishes in writing so that anyone, anywhere, at any time knows what your wishes are. Advanced care planning is a process that involves reflection, learning, and communicating with others. And it's not just a one-time event. It's something that you should revisit throughout your life. Ultimately, advanced care planning considers all of your needs, your medical, personal, emotional, and spiritual needs. And it's not just about old age. At any age, a medical crisis could leave you too ill to make your own healthcare decisions. So let's talk about why advanced care planning is important. Many studies have found that patients prefer good quality of life over quantity of life, meaning that they would not choose treatment simply to live a little bit longer if it meant their ability to enjoy life would be severely impacted. So what a good quality of life looks like is unique to each individual. So for example, a good quality of life could mean to be comfortable and pain-free to one person, or to be able to walk or take care of oneself, or even participate in family events to another person. However, what many patients end up receiving is aggressive medical treatment, particularly at the end of life, with multiple hospital admissions. So what we're seeing is that the care that you may want to receive is very different from the care that you actually receive. And I'd be remiss if I didn't quickly touch on some facts about end-of-life care in New Jersey. So according to the Dartmouth Atlas data, New Jersey patients at the end of life receive some of the most aggressive care in the country. In the last 6 months, New Jersey residents spend 30% more days in the hospital, 44% more days in the ICU, and see physicians 43% more often compared to the average American. And evidence does not show that this increased intensity improves medical outcomes, nor often aligned with the patient's end-of-life wishes. In 2019, the Quality Institute conducted a poll with Rutgers Eagleton Center for Public Interest on New Jersey residents' attitudes toward end-of-life care and found that while residents have given some sort of thought to their end-of-life plans, about 70% have not documented their wishes, and only 24% had spoken about them to a healthcare provider, which really starts to frame why these conversations are important. And furthermore, we found large racial and ethnic disparities exist when it comes to advanced care planning. We found that white residents were more likely than non-white residents to communicate their wishes to someone, approximately 53% compared to 39%, or designate a healthcare proxy, 50% compared to 34%, and document their wishes, which was 37% compared to 20%. So there are three main reasons why we see patients receiving care that doesn't align with their wishes. One reason being growing innovation in healthcare treatments, such as new medications or advances in surgery. And this is, of course, great news, but as a result, it's shifted our attitudes and how we think of or respond to our health and healthcare. We expect to live longer and for our healthcare providers to have an answer on how to help us do that, sometimes not always recognizing the trade-off we may be accepting. A poorer quality of life for a little more time, but if that extra time isn't enjoyable, is it still worth it? And whether your answer is yes or no, the point is that you're not being given the option to decide for yourself and to receive the care that you want. We also assume our healthcare team will tell us everything we need to know about our health, available medical options, and to have an honest discussion about the likely outcome or course of our illness. But another challenge is that healthcare providers are not initiating conversations around advanced care planning, and this is due to a couple of reasons. Many providers, I'd say about 30%, report that they've never received formal training on how to have end-of-life and advanced care planning conversations. They may not have had any training to assess a patient's wishes and goals or know what to ask you regarding advanced care planning. And even when they do start the conversation, about 50% have reported being unsure of what to say. Add in that over time, your doctors and nurses may have gotten to know you and possibly your family members pretty well, and it makes these conversations even harder. In addition, disagreement between patients and their caregivers or family members can prevent advanced care planning conversations from happening. It can create so much conflict and tension that the conversation ends up just never happening in the first place. But the good news is that over the last couple of years, there have been significant efforts to improve provider training on advanced care planning and on how to have these conversations with patients. But we recognize that this will be a gradual process and it will take some time. And that brings us to our last challenge, and that's a challenge that we can do something about today. It's our own lack of knowledge about advanced care planning concepts and low rates of advanced directive completion. So after learning about the need for community and provider education around this topic, we created Conversation of Your Life, or COYL, and COYL's aim is to change the culture in New Jersey around advanced care planning. And we do this in a couple of ways. COYL promotes community conversations around advanced care planning, and we provide education and training to healthcare providers, employers, and community leaders, among others. We help them to better understand advanced care planning, their own goals and values, and how to have these important conversations with those that they serve. We also work to support healthcare policies and technology solutions that seek to improve advanced care planning in our state. So COYL uses a simple three-step approach to advanced care planning. Step one involves considering what is most important to you, what are your goals, wishes, and what are your priorities. Step two, communicate, involves talking about your wishes to your healthcare providers and those who matter the most to you. And step three is create. It's when you put your wishes in writing. This plan will include details on the care you want and who can help make decisions on your behalf if you become unable to make them yourself. So today we're going to look over a case study that will display the importance of considering, communicating, and documenting your wishes. So Rachel, whenever you're ready, the floor is yours.
Hi, my name is Rachel Rubenfeld. I'm a palliative care nurse practitioner at Centra State Medical Center. That's in Freehold, for those of you who are wondering. And let's get started. So our objectives today are to discuss advanced directives and their importance to your health and medical decision making, to learn the different types of advanced directives, to learn the difference between an advanced directive and a POLST. A lot of people don't know that. And tips on how to have goals of care conversation with your chosen decision makers, your healthcare providers, anyone who you want to know what your wishes are. Next slide. This is a case study. The identifying details have been changed. Bill Smith, he's 90. He has a history of multiple strokes and he has some pretty severe dementia. Last summer, his family decided, after a lot of heartache and thought that they needed to put him into a nursing home because he wasn't safe at home anymore. And he was admitted to a memory unit. About a month after he got there, he tripped over something in the hallway and he fell. He broke his hip, and he didn't quite get back to himself after that. In January, he tested positive for COVID and he needed to be in the hospital for an extended amount of time for pneumonia. And up until he came to the hospital for COVID, he was able to feed himself and use a walker. After this hospitalization, he goes to a rehab place to regain his strength, and he's slowly losing function. He's not using his walker so much anymore. He's spending more time in a wheelchair. He goes from being able to eat regular food to pureed food to not being able to feed himself at all. And he showed up in the emergency room last week. He had another stroke. And he's having trouble with everything. He can't move, speak, breathe. He hasn't eaten in a week. And I call the family and I want to know what they want to do. And they have no idea. The patient had never told them what they wanted. Next slide. So looking back, there were multiple points in that case study where the family could have gotten together and discussed what they wanted to do, even though he was no longer capable of having the conversation. Before they put him in a memory unit, they could have had the conversation. When he went to the hospital for his fall, they could have had a conversation. When he was admitted with COVID, they could have had a conversation. And now we have a medical emergency and the family's totally overwhelmed, and doctors and nurses from every specialty are calling from the hospital and they want to know what decisions to be made. Do we want to is the patient going to be resuscitated? Are we going to do CPR? Should we put the patient on a breathing machine? Should we insert a feeding tube? Do they want hospice? And this is the least good way of making decisions. It's too fast. You don't have time to think things over, and it would have been much better to go through things in your mind and with your loved ones in advance. Next slide, please. So an advance directive is a legal document that states your wishes and your choices about receiving medical care if you're no longer able to make decisions for yourself, either because you're unconscious or you're in surgery or you have dementia. And it names someone who can make decisions for you as the authority to make these decisions. It does not supersede your ability to make decisions for yourself when you're fully competent. Only when you're incompetent of making those decisions, either because you don't have, the mental capacity or because you're unconscious, can it be used. And there's several different kinds. There's a living will, there's a durable power of attorney, and then there's a POLST, which is not a legal document, but we'll get to that later. Next slide, please. So this is a copy of a living will. It's a legal document that's used to state your future healthcare wishes in the event that you can't state them for yourself. It describes what types of care you would want or wouldn't want. So some people could say, I do want rehab, I don't want a feeding tube, I do want palliative care. Whatever your choices are, you can have those listed on there. And it is frequently used to name conditions under which life-prolonging treatment should not be used. For instance, sometimes it will say, if I become permanently unconscious and 2 physicians testify to that, then please do X, Y, Z. And some of these treatment options that decisions are often made about, dialysis, when someone goes into kidney failure, feeding tube when a patient can't eat anymore. Do they want CPR? Do they want life support, which involves CPR, but also a breathing machine and medications to keep people alive? Next slide, please. So the living will was one type of document. The durable power of attorney or medical power of attorney is another type of document. And it names someone to make decisions for you. And usually they make decisions based on your wishes, unless you didn't tell them your wishes, and then they have to guess. Spoken to in advance and that they know your wishes, and that they're not going to decide to make decisions other than the ones you would have made as soon as they're in charge. You can name a backup proxy in case the first one's unwilling. But one thing that is very important is to make sure that you only name one person, because sometimes decision makers don't agree, and then that causes a problem. Next slide, please. Those are both legal documents. This is called a POLST. This is the form that we use in New Jersey. It's a practitioner order for life-sustaining treatment. Typically, it's good to fill these out with your primary care provider, someone who knows you well, but we also fill them out in the hospital. When someone is seriously ill or frail, or they have a terminal illness, it gives a bunch of different options for you to list your wishes, and it is a medical order as opposed to a legal document that is signed by your doctor or a mid-level provider. They have to, EMTs and paramedics use this as an order. They can't use an advance directive as an order for wishes. It delineates your goals of care, and we'll talk about that in a little bit. What kind of medical interventions you want, artificial nutrition, whether you would want a feeding tube inserted, or whether you would want a temporary feeding tube, CPR, whether you would want a breathing machine, and it's signed by yourself and whoever you choose to sign it with you. And you can name someone on there as well to be your healthcare representative. Next slide, please. So goals of care, that top slot on the POLST that we were talking about, there's different types of goals. Sometimes your goal is to have full treatment so that you get remission from your disease. Sometimes it's rehab focused. You know that you're not necessarily going to be cured, but you want to do the best you can. Life prolonging or comfort based, which means that you don't really, you know that you're not going to get cured or prolong your life, but you want to make sure to be comfortable. It can be based on your personal or your religious views, whatever your preferences are. And it should be discussed in advance with your family and friends and your support system so they know what you want and they make sure to honor your wishes. You should please leave a copy of your advance directive or your POLST with your primary care provider. And if you ever go to the hospital, please bring it as well. We've on occasion had patients show up in the hospital who tell us they have an advance directive and it's in their house 50 miles away and no one can get it. Frequently we deal with advance directives and POLSTs in the hospital because planning wasn't done in a timely manner. And we want to make sure that, you know, before a patient gets worse, we have something as a plan. Next slide, please. So choosing a proxy is very important because not everyone will agree with you. Let's say you have a comfort-based focus and your oldest daughter, who you would in your mind choose as a proxy, wants you to do everything because she wants you to be around forever. You need to make sure to choose someone who's going to honor your wishes. And you have to be honest and open when you discuss your goals of care, and ask them just point blank, will you respect my wishes? Make sure this person who is going to be your representative has a copy of your advance directive. In the absence of any advance directive, we will talk to your next of kin, your husband, your parent, your children. You know, there's a hierarchy, and they won't necessarily know what you wanted if you didn't tell them. If someone doesn't have any next of kin and the hospital can't contact family, the state may appoint someone to represent you, and they're not necessarily going to have your best wishes at heart. Next slide, please. And when making an advance directive, you need to reflect on your priorities. Do you know what everything is? When someone says to me today, I want everything done, does that mean that you want a permanent feeding tube inserted, that you want to be on a dialysis machine 3 times a week for 4 hours a piece? Do you want to be on a ventilator, knowing that you might not be able to get off? It pays to take some time to educate yourself regarding what everything means. Do you want to end up in a nursing home? A lot of people don't. And when they say, I want to be on a ventilator, they might end up in a position where they have to go to a specialized nursing home where they have a vent unit. What type of disability is unacceptable to you? Pain. You know, some people live with a lot of pain. Some people can't eat. There's, you know, you have to look into what type of disability. Living with kidney failure, living with multi-system organ failure. These are things that you need to think about when making your decisions. Do you want to live dependent on machines? Because sometimes that happens. Making sure that you know who will care for you when you're unable to care for yourself. Do you have someone at home? And where do you want to be at the end of your life? Do you want to die in your own bed? These are important decisions. Or in a facility where your loved ones can't necessarily visit you all the time. Many things to think of when you're reflecting on your priorities. Next slide, please. So sometimes a patient doesn't have an advance directive, and you have to and they're already not able to make decisions for themselves, and you have to make decisions for them. This kind of goes back to our case study, where the family would have been the ones making the decisions for Bill because he had dementia and he wouldn't have been considered competent to make decisions. And going through these questions that I have here for Bill wasn't able to do anything for himself. He wasn't able to feed or dress himself or walk or toilet himself or really do anything, and he couldn't even make his needs known. Someone who has multiple chronic illnesses, do they want to live with all these diseases without having a plan in place for saying, okay, I am okay with treatment until here, but then this is enough. Someone has a life-threatening diagnosis, they have cancer, they have sepsis, they're in the ICU. What would they have wanted? And you really need to think in your mind, it's not what you would have wanted, it's what your loved one would have wanted. Did you ever talk to them about it? Did they ever mention to you, oh, I never want to end up like that? Does a person have multiple recent admissions to the hospital for illness? If someone's heart is failing and they've been in the hospital 6 times in the past 3 months, that's, a sign that you really need to evaluate your priorities. If someone has a neurodegenerative condition and they have dementia, someone who is never going to regain their function and will steadily get worse, or if they had an acute stroke, which isn't slow and insidious, it's fast, and someone could lose all function in a matter of moments. Someone who needs to be permanently placed in a nursing home, what would they have wanted? are you sure that you're following their wishes? And please, everyone have plans in place so that you don't get calls from the hospital in emergency and say, okay, we need to make decisions right now. Next slide, please. So I work in palliative care. And a lot of times when I call someone up and say, hi, I'm the nurse practitioner for palliative care at Centra State. I want to talk to you about your loved one. A lot of times the first response will be, oh, I didn't think we were ready for that. And so, you know, people know palliative care is a specialized approach to treatment of patients with a serious or life-threatening illness, but it does not necessarily mean that there's nothing left to do. Sometimes, you know, we administer something for pain. Sometimes we help arrange for chemotherapy or radiation that will help keep a disease at bay, but won't cure their illness. It will just delay the inevitable for a little bit. If I order pain medicine for someone or something because their breathing is too difficult, it goes along with curative treatment. It's not instead of it. And it isn't the same as hospice care, although we do deal with that as well. Hospice care, in brief, is an end to curative treatment, making sure that we're keeping someone comfortable, managing their symptoms and their comfort at end of life. Next slide, please. And these are just resources for different sites that I was looking up, where you could get more information about making an advance directive. And I thank you so much for listening, and it was very nice to talk for you today.
So thank you for all of that information, Rachel. I want to just inform the members of the audience that you were able to type in questions into the chat box, and we did receive one during the presentation. Yes, there will be a recorded copy of this presentation that will be uploaded to our New Jersey Healthcare Quality Institute website later today, and I will be sending out a copy to all of those that registered and all those that are in attendance tomorrow afternoon. You should receive a copy of that. So I do see we have one. Oh, so thank you. So we did discuss advanced care planning during this presentation. So why is it so important right now, especially during this pandemic for COVID-19?
So that's a very good question. And unfortunately during COVID, someone could have a very light case of COVID, and someone could, and not even necessarily someone who's old, could end up in the ICU, and it can be very sudden. And it's worthwhile for everyone to plan in advance, because no one ever knows whether the horrible cases are going to be them, unfortunately.
And that kind of brings me to my next point. Is there ever really a bad time to have this conversation around advanced care planning?
The very short answer to that is no.
No.
And it's important for people to know that anyone who's capable of making their decisions could have one, and you should ideally update it every few years. If someone's condition changes, or if they change their mind, or if they come into new information that makes them think about something differently, it's never a bad time to have an advance directive.
Thank you. And we briefly touched on hospice and palliative care there at the end, but could you explain a little bit further the difference between the two? So hospice care is typically towards the end of life?
So this kind of becomes an insurance question. There's something called Medicare hospice benefit, and it requires two physicians to certify that a patient has about 6 months left or less left to live. And you have to qualify for hospice. You don't have to qualify for palliative care. Anyone who needs a little bit extra help along with their diagnosis, their treatment, some help with advanced healthcare planning. Sometimes I get consulted and all I do is help them with an advance directive. There's really never a bad time for palliative care, and hospice is a defined situation.
So thank you for that. We do have one question. So do you recommend that we caregivers, even at young 60s, should have these in place? What if our kids are too young to agree to be emergency contacts, but everyone else we know is about our age or older? We can't be sure they will outlive us.
Well, there is the ability to name an adjunct, someone who will step in if the first one is not able to. I would recommend that in young 60s, even younger than that, even 30s and 40s, people make sure that they have their wishes. And you're certainly able to change who your proxy or your healthcare representative is if you change your mind. It really, you should just make sure that they agree to represent you properly.
Okay, so what would happen if, say, you name a healthcare proxy, but you never had the conversation with them that you decided they were your proxy, and you never told them what your wishes were? So what happens in that situation if you can no longer speak for yourself?
In my experience, usually what happens is the person who's representing you will do what they want. And often it's, I want to keep this person around for as long as they possibly can. It's worthwhile to take the time to tell your family members or your loved ones or your friends, whoever's going to represent you, what exactly you want. And there's the possibility of, including in your advance directive, I do not give them the ability to override my wishes.
And we've covered various advanced directives and we keep referring back to them. So how would I be able to go about completing my own? Like, where would I get one and what do I do with them?
They're available on the internet. They're available in most hospitals. Our patient care representatives bring living wills and advance directives to people all the time. We carry posts in the hospital. Most doctors' offices have them. You could hire a lawyer, but you do not have to. You just need someone to witness your wishes. And it can't be the person who you're naming as your representative. It has to be someone else.
Thank you. And so many people have tried to encourage their loved ones to complete an advance directive, but they often find hesitancy or resistance from their loved ones and they just don't want to talk about it at all. They completely shut down. So I was wondering if you've come across any different approaches or conversation starters that patients, physicians, or family members have responded to in a positive way.
I Sometimes people will start the conversation by saying, I watched this movie. What would happen if, it happened to you? What would you do? I was reading this article. Look at current events. This person was in the news and they didn't have any advance directive. Could we, take some time to talk about it? Any conversation starter, really.
And we have another question. Do you recommend that we have both a post and an advance directive?
A post is usually used in the situation of severe illness. If that isn't your situation, an advance directive will be fine. And you can always fill out a post if that becomes relevant. And primary care providers and hospitals are usually pretty good at making sure, at least the palliative care people, that, this is the time for this. I think this would be helpful to you.
Thank you. And the last question I have for you is, so how do you best address the topic with patients of various religious and spiritual backgrounds? In New Jersey, we're a very diverse state. So I'm sure you deal with patients that are across various different backgrounds. So I just wanted to know how it's best to address this topic with those patients.
Very sensitively. You have to make sure that you're very respectful of people's religious wishes, of your, if someone says, according to my religion, I can't do X, Y, and Z, it's best to say, okay. I've spoken to people's priests, rabbis, ministers, that they've asked me to speak to. I don't have any objection to helping people make sure that their wishes align with their culture, their religion, their ethnic background, whatever it is. It's very important to be true to your background.
Thank you. So yeah, thank you, Rachel, for all of that information. It's extremely helpful. And to everyone in the audience, continue to type in questions if you have any, but I just wanted to go over a quick reminder that this webinar will be available on the COYL webpage so that you can review the information you may have missed or share it with your family members and friends. And this is the first part of a three-week long caregiver series. Next week is session 2, April 14th at 12 p.m. It's your caregiver relationship contract, which will have Deborah Hollisey, the founder for Advocate for Mom and Dad. And then the following week, session 3 on April 21st at 12 p.m. It'll be Living with Alzheimer's for Caregivers, featuring Robin Cohn from the Alzheimer's Association of New Jersey. And we have plenty of other resources available for you too, such as our advanced care planning, preparing for the unexpected one-pager, where we have compiled trusted resources which are all accessible from home to help you and your loved ones start thinking about your wishes and strategies for how you can comfortably approach these important conversations with one another and your healthcare providers. So we encourage you to take a look at our COYL webpage and our resources and share it with your family and friends. And stay tuned. We'll continue to push out additional resources and webinars such as this one today. So I just want to say thank you again, Rachel. All this information is greatly appreciated. And if anyone has any questions for me, they can definitely reach me here at dwilcox@njhcqi.org or call our office at 609-452-5980. So thank you very much. And I wish you all to have a wonderful afternoon. Thank you again.